On this episode of WarDocs, we welcome Colonel Dr. Jeremy C. Pamplin. He discusses the mission and evolution of TATRC, the Telemedicine and Advanced Technology Research Center, emphasizing the importance of technology and data governance in military medicine. He addresses the challenges of prolonged casualty care and future conflicts, and the need for innovative solutions to sustain positive outcomes. The discussion also highlights the role of automation and AI in enhancing medical care delivery on the battlefield. Dr. Pamplin talks about the future of robotic agents in healthcare, the challenges of passive data collection, innovative projects at TATRC, and the need for improved collaboration between the DoD and private sector to improve combat casualty care. For further information about Dr. Pamplin and our previous guests, visit our website at wardocspodcast.com. Be sure to follow WarDocs on your preferred podcast platform and subscribe to our WarDocs YouTube channel. I'm your host, Dr. Doug Soderdahl, Army Urologist.
Welcome to WarDocs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, WarDocs has you covered.
Today we're privileged to welcome back the commander of the Telemedicine and Advanced Technology Research Center, TATRC, Colonel Dr. Jeremy C. Pamplin, to WarDocs. Jeremy, thanks for joining us today.
Hey, Doug, thanks for having me back again. It's just such an honor for you to bring me back to this program. It's been amazing to watch the growth of it and yourself and how it's really started to change some of the conversation around military medicine over the last few years. I'm extremely privileged that you brought me back on the show.
Well, thanks for being here. And TATRC is something that is really important, and some folks who listen to us don't know a lot about it. Could you tell us briefly about TATRC's mission?
Sure. The Telemedicine and Advanced Technologies Research Center, or TATRC, as you have highlighted it, is the DoD's only really advanced technologies research center or research laboratory. It's had a bit of a storied past. It's grown up ever since the early 1990s when it was really came into existence to develop remote teleradiology. And if you are familiar with radiology these days and the concept of the PACS system, where we're able to send digital radiology kind of from any point to any point, that all began in the early Medical Advanced Technologies Management Office, or MATMO, that then eventually became TATRC in the late 90s and then grew through the early 2000s. The mission for telemedicine really became paramount in the early 2000s. At the same time, the congressional special interest kind of curve swung up. This was back in the time when TATRC was more like a congressionally directed medical research program, or CDMRP, and really was a sponsorship organization. It moved money and sponsored organizations on the order of hundreds of millions of dollars, and really did some amazing work with that research, including developing the Time Invention of the Year, which was the BEAR robot, or the battlefield extraction robot. You can see that spattered all over the internet in various different places. Still the first and I think only robotic agent that's really been able to successfully pull casualties off a battlefield in at least a research environment. And then, the telemedicine evolution grew alongside the American Telemedicine Association, really through a lot of investment of the TATRC resources. And then as the special interest money started to fade out in the 2010s, we separated most of that execution management work over to CDMRP and became an actual research lab focused on research development and technology, RDT&E space. When that occurred, TATRC's size, significantly declined, and we really didn't have a specific mission to research any specific element of combat casualty care. It was really technology development at scale, or broadly. And over the next decade or so, again, TATRC continued to invest in a lot of the early research careers of folks across the military through the Advanced Medical Technologies Initiative. Used to be the AMED, Advanced Medical Technologies Initiative. That tool helped many of us start our research careers, and has still led to many phenomenal innovations across the enterprise that are still in use today. my career started, my tenure at TATRC really started to evolve. In 2018, we started recognizing the need to really transition our work over into the AI and automation space. General Tally came on board and recognized the importance of how TATRC develops tech. It's not just about the tech, it's really about the team. And we had implemented the use of medical simulation, which many of us are familiar with training, and I'm sure this theme is going to come up later in the talk today. But the use of medical simulation and really high realistic or high fidelity med sim, and then ultimately hyper realistic med sim that looks almost identical to real combat casualty care, with some really important differences, but looks and feels very much the same, generates the same cognitive demands, the same stress levels that real combat medics have, using that platform to really understand how tech should be developed, and how technology affects the care that is delivered, the decisions that are made, and then at some point in time, at least some standardized outcomes. And the combination of using that user-centered design or soldier-centered design in the high fidelity med sim area as it's related to technology development and evaluation and testing, those two pieces together, which we call the nexus in many ways, of development, assessment, and kind of comparative effectiveness research, that became what is TATRC today, and led General Tally and General Murray, who was the first commander of Army Futures Command, to designate TATRC as a formal command under the Medical Research and Development Command. And we became a command in 2021 with a mission to, at that point in time, forge the future by fusing data, humans, and machines into trustworthy solutions that optimize medical performance and casualty outcomes, with a vision of fully autonomous care. And we've kind of truncated those together to automating casualty care by fusing data, humans, and machines into trustworthy solutions that optimize medical performance and casualty outcomes.
So let's jump right into the practical and the future. One
Sure.
of the questions that keep many in military medicine up at night is, how do we sustain outcomes that we become accustomed to in past conflicts, but now in the context of prolonged casualty care, potential massive casualties on the battlefield? What are some of the primary concerns that we should be evaluating to medically prepare for that next conflict, especially in the autonomy and AI area?
Yeah, as you know, this is an area that I'm very passionate about, given my background in critical care, trauma critical care, burns critical care, and then the evolution that technology has had, particularly telemedicine, alongside of the prolonged field care and now prolonged casualty care space. That journey of prolonged casualty care with resource limited care context is very similar to large scale combat operations and massive casualty numbers. In both circumstances, you have resource limitations that constrain your ability to provide maybe the care that you would optimally want to provide, whether that's through evacuation or through just resource limitations. And those resource limitations may be not just of supplies, medications, and equipment, but also of human knowledge, skills, and abilities at the point of need. So, if your casualty needs a surgeon and there's no surgeon available and you can't evacuate, how do you deliver trauma surgery to the point of need wherever the casualty is, rather than having to move the casualty through the care continuum for a variety of reasons? The system, the enterprise, has talked about these challenges over the last several years. One of the narratives is that we will not be able to maintain or sustain the outcomes that we have grown accustomed to in future conflict because of these constraints that I just highlighted. Because we will have too many casualties and we won't have enough resources. We just have to expect that more casualties are going to die. That has always kept me up at night. I'm very, again, passionate about trying to support not just the casualties who need the best care possible, the American sons and daughters whom we need to bring home, to include my son. And I know many of the listeners' children who are out there who are now active duty, and may find themselves in harm's way in the future. We must, we don't want to settle for there just likely to be more death and more morbidity amongst our children, our friends, and our family. So how do we change that narrative? How can we hold ourselves accountable and actually try to sustain the same outcomes that we currently have despite these constraints? And my journey, my career arc has always led me towards, the recognition that humans create technologies in order to be, faster, more efficient, to be smarter, more capable, to be stronger, to last longer, to do more with less. We went from walking to a horse because nobody wanted to, walk the distances that a horse could, and we went from a horse to a buggy into a car because they go way up and down mountains all day long as you have enough gas, whereas the horse gets tired and you need to change them out. So developing technologies is the way that humans advance their ability to get work done. And I strongly believe that we can find technologies that will address the challenges related to large-scale combat operations, prolonged casualty care, and massive casualty numbers. Ultimately, those will come in the same standard formats, the .mil PFP solutions, doctrine, organization, training, material solutions, which obviously we're largely invested in developing, leadership, personnel, facilities, and policy. But you have to have a mechanism by which you can inform those changes. And I strongly believe that if we get our data space the right way, done the right way, just like the Joint Trauma System has done for years, reviewing, analyzing data that's collected in the real world to understand patterns, that we can inform the .mil PFP changes that are necessary to ultimately accomplish, the right optimization of our casualty care and ultimately the outcomes that we're interested in.
So currently, right now, medical care is so human oriented. In the looking at the future of large scale combat operations, going back to a World War II, where you just have massive casualties, all kinds of stuff going on. In the future, we'll have drones and other things that are going to make us worry. Right now, do we have enough human assets to even care for the casualties that we're going to expect? And is that really kind of lighting the fire to, do what you guys are doing, which is to augment that care capability?
I get this question a lot, right? Because there's always a trade-off between investing in the human and investing in new technologies. I personally don't see them different, right? I think that if we provide our investments wisely, we invest in the right technologies, those technologies will augment the humans. My team and many people who've heard me talk before will recognize the phrase, it's not about it's not about the tech, it's about the team, right? And what that means is the technology only goes so far. If you don't have the technology working with the humans the right way, then the humans don't adopt the technology, and the technology really doesn't survive first contact. It's not going to happen overnight, right? This is an evolutionary and interim process where we bring the right tools to bear at the right time to ultimately change the way that we deliver patient care. I think that there will be times when you get more rapid kind of revolutionary change, maybe a little bit like we saw during COVID and the telemedicine experience. But telemedicine existed for a lot of years, way before COVID came into play. If it hadn't existed during all those years and all those kind of interim evolutionary changes for years before COVID, it wouldn't have been ready for COVID. It was the fact that it was already a fairly mature technology, that it was an easy button during COVID in order to adopt that specific piece of technology. And I suspect that, our future tech space on the battlefield will be similar. We'll have certain pieces of technology that will be in place that will augment what humans are already doing. And the ones that are most mature will be able to have an opportunity for revolutionary investment and alterations with how we deliver casualty care in the future. But it magically comes to bear overnight. I'm sure we'll talk at some point in time about the evolution of the autonomous car driving industry. But it's going to be more like that than it's going to be like some magic that people somehow or other perceive technology as being. Sometimes it's not magic, it's engineering, it's good science, and it's interim and evolutionary change.
So, speaking of good science, you focus a lot on quality data and trying to build a good case for data governance. How does good data governance help us achieve our goals of sustaining those positive outcomes that we've, like you said, grown accustomed to in previous conflicts?
It's a great question. And I think there is still a lot of differences of perspective within the military healthcare system about what data is important, and what data can be used for. It's not just in the military healthcare system. I'd argue it's probably just in the medical system in general. For many, many years now, medicine has been I don't know, beholden to, anchored by, invested in the electronic medical record. And the electronic medical record generally delivers, all the kind of ecosystem for the data that we tend to use in medicine to take care of patients at present. The challenge with the electronic medical record is that as soon as data is entered into it, it's all old data, right? You have to have taken care of the patient before you write your note. You have to perform the operation before you document the operation. You have to have done your history and physical and your laboratory collection and your vital signs monitoring before you can put that information into the electronic medical record. As I'm sure many of your listeners are aware, if a casualty or a patient falls in front of you, and you don't have any electronic medical record, and you don't have any vital signs data, and you don't have any laboratory data, no radiology information, you still take care of the patient, right? We have processes by which we immediately start managing a casualty no matter what data is or is not available. So for me, that's always driven the perspective that it's really not about the data that's in the electronic medical record that allows us to take care of patients. There are absolutely certain times when electronic medical record data, historical knowledge is useful, but in the absence of that information, we still do an assessment, we still take care of the casualty. Therefore, there must be another data set, another information hierarchy that's out there that clinicians use to manage patients. And for me, that's passively collected real-time data in the form of audio-visual information, perhaps environmental cues, perhaps accelerometry data, perhaps other tools that we might be able to put in place, sensor data that we could put in place that will automatically collect information about casualty status, who the casualty is, what's wrong with them, what their current condition is, caregiver actions, what the caregiver does. And it's not all about treatment every single time. Sometimes it's about coordinating care. It's about, hey, yelling out and asking for help, or yelling out and say, hey, can somebody go get that for me? Can somebody call the 9 line? Can somebody else help me document what's going on so I don't lose track of what's happening? And then also the resources that are used to manage that casualty. The other piece that's not in the electronic medical record that's incredibly important for medical decision making, the context of the environment that you're providing the care within. And what I mean by that is how many other caregivers are around, how many other patients are around. Humans know when they're going to be able to get evacuation to them, or have a general sense of that. They know where the casualty might go. They may even know who's at the next level of care. They may know the battalion surgeon or the actual surgeon that's at the role 2 or the role 3. They may have insights as to what resources are or are not available along the care continuum, or even in the back of the vehicle that's coming to get their patient, the evac platform. And we are aware of certain cases or scenarios when medics have changed evacuation order based off the vehicle that's coming to pick up their casualties. They know the first vehicle doesn't maybe have blood on it, or maybe doesn't have an experienced caregiver on it. It's a junior or novice provider. And they know the one that's coming behind them, maybe 5 minutes later, is more experienced or is carrying the blood. So they'll change their evacuation order. It's really not about first in, first out. It's about something else that we don't have available in our electronic medical record system that helps us make some of these really important decisions about casualty care. And I think that if we can put the right tools in place to collect that kind of data, we'll start to be able to better understand the ecosystem within which we provide our patient care, and then ultimately be able to make that more efficient, more effective, more accurate, more reliable, and really start to be able to change how we think about developing requirements for the tools the technology that we're going to invest in, and the .mil PFP changes that we'll ultimately make. And I think we're very much on the cusp, the early part of that investment, and then that data strategy. You asked specifically about data governance and kind of, data quality and data importance. And I'm just gonna throw out some buzzwords for a moment, but they're important buzzwords because they're buzzwords that I think most of our enterprise lacks fluency within. And if we don't understand some of these kinds of buzzwords, we don't understand the importance of really putting time, effort, resources, and investments into not only our data strategy, but the data infrastructure that we have, as well as the data governance and the policies that are related to it, and then ultimately the solutions that we'll be able to derive from it. So governance is highly important for all the data that we're talking about, and we think we have good governance in place, but I don't know that we're always applying the right lens to the governance that we have. So governance is policies, roles, and standards, right, for the data that we might collect. And most of them are focused around the electronic medical record and garrison-based healthcare. But they don't enforce things like interoperability standards of medical devices, right? Which makes it really hard for us to do modular development or to pick a new novel technology off the shelf and implement it in our system. We have to upgrade those new medical devices to either old standards or decide that we're going to invest a whole bunch of time, energy, and resources into upgrading our current standards to fit the novel medical devices. So that's a real challenge. Also within the governance space is just, we're specifically related to data, is our accountability, integrity, auditability, standardization, quality. I'll come back to that in a moment, and just kind of the change management of the data. All of those individual line items of governments take time and effort. And clinicians don't really think about it because we offload these things to IT. The challenge with it in the IT space right now is that IT is primarily concerned with security and the auditability of it, of that data and some of the accountability parts, but not necessarily the value of that data. And I'll go over to the kind of 5 V's of data that are important to our data efforts and our data strategy. And those 5 V's are volume, velocity, variety, and veracity, which is the accuracy and reliability of the data. But probably the most important V of those is value. Why is this data important? And oftentimes, particularly in electronic medical record, the data that we're collecting is not important, right? How often do we go back and look at the pre-hospital data that's collected prior to taking care of the patient? Oftentimes, none. We've done this during some of our test and evaluation events where we have 1380s, the pre-hospital combat casualty care card that's written, and we hand it over to the role 1 or role 2 providers as the casualty's coming in, and they immediately put it in their pocket, take the handoff from the evacuating medic, and start managing the casualty. They've never even looked at the 1380. So why are we collecting that data if it's not important to the patient care? Oftentimes they'll go back and look at that 1380 for when the last medication was given, or maybe what the last set of vital signs were documented after they get their first set of vital signs, but it doesn't drive the care that's being provided. And we know that because historically only 15% of our 1380s have ever been actually collected. So what were all those role 1s and role 2s doing without 1380s? They were still taking care of patients. So this issue of value of data becomes really important. And I think those two pieces together, if we can really start focusing on some of those elements of data, the governance process and the 5 V's, or the qualities of data, we can start making a lot of progress with collecting the right information to actually change the way we deliver patient care on the future battlefield.
So you kind of mentioned that we're on the cusp of, kind of using what we're seeing in the data and what we're learning to, make some changes in how we care for patients on the battlefield and, throughout the continuum of care. How do we prioritize what caregiver tasks or even decisions that can and should be offloaded to automation?
I was afraid you were going to ask me that question. There's almost no right answer to that question. I get in a lot of trouble trying to imagine, the future. I was reading a book recently where they had this concept of useful fiction, and the premise behind useful fiction is that you can generate fictional narratives that are based in either scientific data or discrete observations, right? That actually provide a better picture or a better understanding to other people about what your science, what your data, what your observations mean. And I use this technique often to describe the technologies that TATRC is trying to develop, or the direction that we should go. But the stories or the fictions don't necessarily account for this is exactly the right answer, right? They are concepts. The reality of automating care, though, or automating any process, is that requires, there are requirements for automation. That those requirements are reflected in what we call the automation stack. The automation stack is a vertical kind of process, stepwise process where you go up the automation stack. But it's not dissimilar to what people or listeners may refer to as the OODA loop: observing, orienting, deciding, and acting. That infinite process where any AI system, doesn't have to be AI, any intelligence system, humans use the same process where we observe our environment, we orient ourselves to it. In other words, we see our environment or sense it, we orient or understand what's going on in that environment. We make decisions about what to do next. Sometimes that decision is to get more information, go back to the observe part and then the orient part, or we act upon it, right? And that could be a physical action. That stepwise approach, which is in our version of the automation stack, is sense, understand, decide, and act. You can make each of those steps autonomous, fast, passive almost. And each time you iterate upon each component of that stack, you save time, right? And you save time for a human. So let's just take, for example, sensing, right? If we could collect data and put it someplace, well, that would be helpful, right? If that data was then available, let's just give an example. If I were to automatically take a picture of a casualty and put it someplace, that would be a radical change to how we collect data on a battlefield. But some registrar, some future state could look at that picture and probably recreate a 1380 almost instantaneously from that image, and we'd have the ability to generate understanding, right? That's just the sense part. Let's make that process automatic. Just have a video recording, an audio recording that some human could look at a later time. You can have a human look at it at a later time. You can probably have a machine look at it at a later time, right? And that's AI, right? You have an AI evaluate the passive data that's collected. And now all of a sudden we have understanding of that data without even a human in the loop, right? The machine can say, hey, here's what I think is going on. Here's a list of all the things that occurred in that picture. Here's the casualty, information that was available from that video or from that picture. We could then use that discrete data elements from that computer understanding to create documentation, to create inputs to other processes, to create visualizations of the battlefield in ways that we haven't really thought of before. We can then take that understanding that's generated from both, maybe it's a machine initially, right? But maybe a machine with a human concurrence to it for legal documentation purposes. We can call that autonomous documentation. That's a project that TATRC's currently working on, right? Passive data collection with sensors to AI generated understanding of that data or discrete data elements that can flow seamlessly into a digital 1380. That would be phenomenal, right? Now we've saved all the time that humans are currently spending documenting patient care, which, oh, by the way, we know is somewhere in the order of a quarter of the time that they're taking care of a patient during at least a 20-minute one of these high fidelity med sim scenarios is spent just documenting care in a 1380, on a paper 1380. That kind of insight is helpful for our .mil PFP solution development processes. So again, we don't have to go immediately to a digital or technology solution or an AI or autonomous solution. We can use the data collected from these tools to make better insights, just like the Joint Trauma System does from human collected data. Automating sensing, automating understanding, right? You move into these decision-making processes where once you kind of know casualty status, know what actions should occur for that type of a casualty, know what resources are necessary, maybe whether those resources are available, the machine can start maybe making recommendations. Here's some things you should be thinking of. Maybe it can even check some of those things off. And as you check those things off, maybe the machine can give an alert. Hey, you forgot to do something. Implement that into the TC3 guidelines, have the machine track what you're doing. And then you can say, hey, I've done better patient care because the machine is watching what I'm doing, or provide clinical decision support for somebody who doesn't know what they're doing. That same data, that same decision-making process, once the machine is confident that it's making the right decisions, recognizing casualties the right way, making decisions the right way, we can start implementing into actual treatment algorithms, right? Where instead of the human having to say, yeah, I need to do that, the machine recommends you do it. Now, all of a sudden, you don't need a trained medical provider. You just need somebody who understands what the right tasks are, and they don't even know when they need to do it. They just need to say, the machine's telling me to do it, I need to do it. Now, that's a long way in the future. We're still 10, 20 years down the road before we have a machine telling us exactly what to do. But you know what? We do this already for cardiac patients. It's called an AED. I mean, medical people don't need to be on the scene when a patient goes down or a human goes down and has a cardiac event as long as they get an AED and know how to do chest compressions. They just need to be able to follow directions from the machine. So eventually the machine makes some of these decisions for us. The humans are still maybe performing some of these actions. Eventually we teach the machines to be able to do some of those actions, right? What are some of those actions that might be relatively low-hanging fruit? Place a tourniquet. Okay, so could a machine be made that could automatically place a tourniquet on a traumatic amputation? Probably. Could it be made to automatically place a IV in an available blood vessel or central line or an IO into a bone? The answer is probably. Why do I know this? Because these are already have prototypes in labs in a variety of academic centers around the world, right? So it's probable that we'll have machines that can do some of these tasks that are necessary to deliver other therapies. And once those things exist, then we just need to make the decision to do them. And whether or not that's a machine doing it on its own or a human saying, yes, please do that, we could deploy maybe a robotic agent, quadruped, biped, snake robot, whatever form or fit that you might want to imagine. But we could deploy this kind of non-human physical agent to do some of the tasks for us in a tactical combat casualty care scenario or in a large-scale mass cow scenario. Maybe it drops from the sky from a drone. I mean, you can come up with all kinds of different robotic agents that could help us with these tools in our future. But it's not out of the realm of possible for us to consider these in our future.
Just listening to you talk about that, it seems like, there are commercial companies that are just well ahead of the DoD and military medicine on this automation stack. I think of Amazon, Uber, Tesla, DoorDash. They have this data ecosystem that, the machines are making the decisions that humans used to, and they're acting on it. What is keeping military medicine? I mean, why is it 20 years from now? Why is it not 2 years from now?
You haven't seen those same types of changes yet in healthcare, partly because I think the stakes are somewhat higher in healthcare, right? Humans desire to have autonomy over their own bodies. They have a strong investment in the outcomes that come from their healthcare. So there's a patient aspect that is a bit more leery about a machine making a decision about their healthcare than about whether or not their food arrives on time or their package arrives on time. So there's an element of trust amongst the patient side of this. A similar challenge exists on the healthcare provider side related to trust, right? Trusting the AI systems. And I think if any of the listeners have used a chat GPT or a large language model to help, with either research or identifying references for a manuscript, they know that there are some challenges in some of the systems with hallucinations and their ability to, create entirely fabricated information that just sounds really good with the available information that's online. And that generates an element of caution for all of us to trust the AI systems as they currently exist. Training an AI system is also not magic. It takes time. It takes the right data. If you train the AI system on the wrong data set, it comes up with the wrong information, right? It will come up with biased recommendations. It will come up with hallucinations. It will come up with false narratives. So having the right data set to train your AI models on is imperative to getting trustable AI. In order for us to really achieve or realize the types of innovations that some of the companies that you mentioned are currently experiencing, we would have to change our perspective on our data ecosystem and make it much more real time, much more passive data collection. And that's just a different investment strategy than investing in digitization of the electronic medical record or digitization of our registry work, right? It's one thing making data flow seamlessly from one record to another. It's another thing imagining an entirely new way of collecting that data that doesn't involve humans in the loop at all. And I think that's one of the struggles that we just have right now. We've got a lot of momentum and a lot of emphasis, a lot of history behind both the joint trauma system and the significant quality improvements that we've had over the past 20 years, getting data from the electronic medical record, from our JTS phone calls every Thursday, that we, in order to imagine a new way of doing this, we have to make a decision about whether or not we continue the old way, stop and start over, or somehow or another fuse those two together. And fusing those two together is probably the right answer, or hybrid solution, but just takes time.
So you talked a lot about, this data collection being passive and autonomous. Where do we stand with, those data collection systems that are replacing human senses? So cameras out there, sensors, wearables, where are we currently with doing that passively and autonomously?
I would say not very far. All of the efforts right now are in the RDT&E space. I'm aware of some international partners and some research efforts that looked at using cameras to collect data during simulated care contexts. We have a lot of challenges around medical culture, particularly clinician culture, of being concerned about whether or not they will collect data that will hold them accountable or liable for a mistake. And I think that's probably going to be fairly easy to overcome, similar to the police body cam experience early on in the wearable cameras for policing. There was a lot of concern that the cameras would identify some sort of nefarious behavior or problematic behavior amongst policing. And more often than not, the cameras, in fact, almost 98, 99% of the time, the cameras vindicate police for being professionals in their jobs and doing the right thing, despite what the individuals that they're interacting with claim. I think very similarly, the medical, the healthcare space is full of medical professionals that do the right thing 98, 99% of the time. There are mistakes that occur, but usually those mistakes are in pretty controlled environments, and people can recognize why they occurred, and it's not always someone's fault, right? It's usually a systems problem that causes most of our error. So I think we'll eventually overcome some of the barriers of culture to collecting this type of data, but it's going to take some time. And I think the first place that it will come will be in our training environments, right? Where we can, deploy these types of sensors, watching the kind of care that we provide in training, and generate more meaningful, near immediate feedback type after action reviews from real-time data. And this is very much like what professional sports teams are currently using for almost all their games and really almost all their practices, I think, where they're being recorded continuously. And as soon as they're done with their game, done with their practice, they get a report. Here's how you did today. Score yourself. Tell us how you did, right? And you get to compare your scores to where the coach in the clouds, the coach that's sitting up in the coaching's box, he or she scored your game, and now you got to compare your score to their score and see where there's differences. And where there's differences, those become conversations. And when you develop those types of tools that allow you to understand your performance in real time, it's going to change the narrative for how we train, right? And as we change the narrative for how we train, that'll immediately impact the way that we improve casualty care kind of over time. It will start to implement how we do our .mil PFP kind of requirements, and all those will be really important. But until we can figure out how to get cameras on all the people that are providing the patient care, and I'm specifically talking about combat casualty care, not necessarily garrison-based healthcare, that's another environment that we can go into. But it's going to take probably even more time there, because you got a patients and their patient privacy, set of rights, all those types of issues that can be done in research domains, but it's not yet standard of care. So it's hard to get some of those things in some cultures to buy off on putting ubiquitous data collection in some of these environments. I'll say one more piece that's also really important just for this conversation. One of the things that's essential for training AI is data. And we don't do a lot of combat casualty care on a regular basis. Because we don't do a lot of combat casualty care on a regular basis, where does our data set come from? Could it come from other conflicts around the world? The answer is sure, it could. Could it come from the civilian EMS system where they take care of trauma patients, at large, every single day across the U.S. healthcare system. Sure. The challenge is going back to what I said before about machine bias. If you don't have the right data set, the machine may not recognize the information coming in and understand it the right way in order to make the right decision. And all three of the contexts I just mentioned, foreign militaries doing casualty care, the civilian healthcare doing trauma care, or even our garrison-based healthcare, they all have different providers that are within them with different training sets, with different resources available to them, with different times, durations of evacuation or times from point of injury to hospital care. And all of those pieces are really important to have a machine that's going to recognize what the right intervention to do at the right time, how to bin casualties, just like we talked about early on. Clinicians, humans keep all this nuanced information in their head, and it's not available in electronic medical record. If we don't have data sets that capture that type of information for U.S. military combat casualty care decision making, then there is risk that the AI models that we train will be biased and then untrustworthy by the clinicians that will be using them. And that's not just care at the point of injury, right? We need systems that are going to collect this data across the care continuum, from what I call role zero, which is the pre-casualty space. So, wearables to understand casualty healthcare status before they're injured, to the point where they have an inflection where they go from I'm in the fight to I'm out of fight. Now I'm a casualty, I need medical help, right? To point of injury care, evacuation care, role one, role two, role three, role four care. A data system needs to be in place that's collecting all that information about casualty status, caregiver actions, and resource consumption in real time that allows us to model it in such a way that we can understand each individual's casualty's projected journey or digital twin across that care continuum. Which, oh, by the way, digital twinning is exactly how Amazon, Uber, DoorDash, all the companies you just mentioned, do their work, right? They digitally twin a package, a car, a food order, and understand how to predict when that element is needed at a specific location, and what the most efficient pathway is of resources that are required to get that element, package, food order to the place it needs to be at the right time.
So I don't want this to be like asking a parent who their favorite child is, but give me an example of a cutting edge project that TATRC's working on that's really, really interesting to you.
There's a lot of them that are really, really interesting. Can I do two?
Sure.
Okay, it's my favorite son and my favorite daughter, maybe, or
Okay.
vice versa.
All right.
So I think the one that captures most of the talk that we've been having thus far is what we call the AutoDoc project, or autonomous documentation project, which is a bit of a misnomer. It's really passive data collection to autonomous documentation. So we have to get the passive data so we can train the models to produce the autonomous documentation. And the reason we started there is because there's a lot of elements of our conversation that I hope the listeners have picked up on. Is we don't exactly know what the right answer is. I never directly answered, what do we automate first? I kind of went up the automation stack. But there are other options that are out there, right? We could identify something that is fairly easy to automate, like mechanical ventilation, since they do that in Europe already. Maybe it's sedation delivery in the operating room for anesthesia. Those autonomous processes are relatively more contained and maybe more amenable to full automation before we get to some future vision where we're digitally twinning all the casualties and we can have robotic agents helping at the point of need. But AutoDoc, in my mind, and in TATRC's mind, our scientists, our team, is kind of the foundational step to starting the digital twinning process across our care continuum that can hopefully start to transform how we deliver casualty care in a future battlefield. And the reason is because it creates that foundational data set. It creates real-time passive data about casualty care at the point of need. You can implement these sensors, whether they're at the point of injury, at the evacuation platform, in the holding area, at the role one, the role two, or the role three, wherever you want to put them. It's not magic. These are just cameras, microphones. Maybe you put some other things in place. Maybe it's a thermal camera. Maybe it's an accelerometer. We don't know what the right kind of mixture is of sensors, at different points of the care continuum are, and maybe they're different at different points in the care continuum. But the concept that we can collect passive data in real time across the care continuum creates this foundational data set. That foundational data set then goes up to the cloud. In the cloud, we get to model it. We can model it to do all kinds of cool stuff, right? The first model is documentation. Why is documentation important? Because it's something we all need. It's archival. It's a requirement, right? We are required to document a patient's care. We're not required to make it necessarily better. There's no requirement that says make patient care better. There is a requirement to document patient care, so we can document patient care. Can we do that at the point of injury? Sure, let's try to do it there. If we can do it at the point of injury under a bush, it's way easier to do it across the care continuum where you have more resources to do it, right? Where you have, more storage, more cameras, more cloud, more network, more everything. As you move up the care continuum, it gets easier. So AutoDoc is, I think, a foundational project which really starts building what we call base camp of the of Mount autonomy. We've kind of published on this, right? If you have foundational data collection and a little place to store it and a place to model it and a place to share it, right? This is this data commons environment, then you can do amazing things with the data that you've collected. Eventually, that data, that core data set that we get from training, research and training environments will eventually come from real world environments too. We'll eventually put cameras on medics, microphones on medics, and maybe some other sensors on medics, and we'll get actual real combat casualty care data that we can validate models developed from the research and training domain on and confirm that those models actually are valid, and they work in real time and can be used for actual documentation. So I think AutoDoc is maybe my favorite daughter.
Okay.
My favorite son is probably just starting to come to fruition, and it's this construct where we're creating human machine teams through several robotic agents maybe. So maybe it's an off patient, an off provider camera source. We call that Vista right now. It's a vision intelligence systems for teaming applications, Vista. And that system can watch from any camera, whether it's a drone in the sky, robot on the ground, a fixed camera, wherever it might be, and kind of understand the casualties that are in the picture, their status, what's going on with them. And then you can apply robotic agents to move within that scene to help with certain tasks, right? And we have some examples of this on some video on both our website. An original partner for this was actually Johns Hopkins Applied Physics Lab. No endorsement necessarily, just they were a partner that helped create some of these videos. And you can imagine a quadruped robot that can move around the direction, maybe the voice control of a medic to do certain things from essentially apply a second set of hands. Because what's the most critical resource in TC3? It's like an extra set of hands. Hey, can you grab that for me because you're in the middle of packing a wound or putting a tourniquet on or holding pressure or placing an IV and you forgot to grab something, right? Or, hey, I need the next thing that's going to be available to me. And you can imagine right now we do that all with humans, or you have to take your attention away from the patient and grab it out of your aid bag. If you don't have to do that and you have a robotic or human agent, eventually a robotic agent that's helping you, that would be hugely beneficial. And we're getting ready to start that project hopefully next summer. And I think that's going to be a game changer to start developing some of these human machine teams that can exist in complex environments to understand not just what's going on, but what's the right interface. And we don't even know, should it be a quadruped robot or should it be a snake robot? Should it be a biped robot, something that looks like a human? These are all these really kind of important engineering questions that we don't have answers to because we've really never had an environment where we could test and evaluate these types of tools. And we've created that with our medical simulation space.
When you were talking about the, kind of the history of TATRC, how it was initially related to the congressionally mandated research projects. And so that was very much, kind of partnering with the private sector. So how does the DoD partner with the private sector to solve some of these tough problems that you're talking about?
That's a great question. I don't know that we always do that well. There's, again, I think maybe two schools of thought. One is that the military has to develop all of its own stuff because it's really hard to develop stuff for the military mission. The other one is, man, the outside world, the commercial partners, industry partners, academia, they're so much more agile and so much faster at developing stuff. Let's just let them do all of it for the military. And kind of like my answer about what's the right data strategy, do we do the old way or the new way, or a combination of both? I think it's both. I think there's value in having military researchers who understand our mission sets, our problem areas, our challenges, and have access to, our community that it's hard to get from civilian or academic partners. But at the same time, there's some civilian academic partners, some of their knowledge, skills, and abilities, particularly in the areas of robotics and AI, that we're just not going to be able to home grow probably in the military and retain because Amazon, DoorDash, Uber, Apple, you name the company out there, they can pay a lot more for a data scientist, AI engineer than can the U.S. military. We need some of those folks to understand, how to talk to, the right data scientist, the right software engineer, but we may not have to be the expert in it. We may not have to be the world leading, subspecialist in data sciences that will create exactly the right tool. But we need to know how to partner with them. I think I heard one of our senior leaders say not too long ago that we don't need the expert scientist. We need the expert scientist that knows how to solve problems in our midst. And I think that's probably a good analogy, right? We need the right people that can solve problems within the military context in order to partner with the academic civilian sector to develop technology most effectively for our needs. The other piece that's I think really important, I'll kind of say kind of our model here in a moment, but is the civilian sector is never going to have access to all of our data. They're not going to be able to collect our data for us. They're not going to be able to own our data for us. They're not going to be able to create an environment where we can store for archival purposes or for modeling purposes for an extended period of time. We're never going to give that authority to some civilian entity to do that for us, I don't think, for a variety of reasons. Security, both cybersecurity and security of information. As you start aggregating this type of data, the classification of it starts likely going up. So we're just unlikely to give the authority to an external entity to own this data space. We're going to need to have a place to keep it. We're going to have to secure it. We're going to have to be able to know how to share it in the right way. We can do that, right? And the way that we do that is through contracts and sponsorships. And there are very flexible ways that we've learned, TATRC in this case, have learned to share information and to work with academic and industry partners to solve problems. And I think one of the most flexible ways is other transactional authorities. It's just a contracting mechanism. Our most effective one right now is the Medical Technologies Enterprise Consortium, and through that contracting vehicle, we were able to identify a problem, identify initial concept about how to solve that problem in the form of a grant, and then as we go down the path of solving that problem, we realize some of our initial assumptions about solving the problem are wrong. This is a very DARPA-like model. And when you realize that they're wrong, you allow through the OTA, the teams who are performing for you, to alter their strategy, right? Or maybe shift focus, right? Or maybe to combine some of their efforts in such a way that they're all working on the same problem together for a period of time. Or maybe stop doing some work because one of the teams is really doing it better than one of the other teams. And that kind of flexible model is really the direction I think we need to go for developing technologies, because we need to be able to keep pace with the civilian world, but we need to do it with the military mission in mind. The other thing I'll just say is, the civilian sector is phenomenal at developing the tech, but within our context, it's really hard because, developing a tool that works on the side of the road or in a sterile laboratory environment is not the same as using that piece of tech under a bush in the mud with the sounds that are going on around us. Anybody who's in combat knows it's just doesn't sound like the side of the road, even if there's cars rushing by you. Bombs, explosions, gunfire, shouting, all those things are different than it sounds like on the side of the road or in any of our research environments or academic industrial environments today. So you have to be able to recreate those types of very realistic settings in order for the machines to get the right type of data in order to make the right type of algorithms so we can understand what the information means, then ultimately make the right decisions that will lead to the right actions.
So I think looking back, seeing our good outcomes that we had from previous conflicts, I'm thinking OIF, OEF, a lot of that stemmed from kind of on the job training. We just got good at doing what we were doing because we were there doing it. And, you mentioned that we don't have that. I mean, I'm not going to call it a luxury, but we don't have that right now. And yet we're still deploying humans to take care of people in austere environments. What do we have as far as training using simulation? What is the best that we can do right now to help our medics and other deploying healthcare professionals be as ready as possible to face future care challenges and not have to just say, "Hey, I hope we just learn, as we get there."
So I am not the expert in the training space right now. I still I try to maintain situational awareness of what the Medical Center of Excellence is doing, the concepts around a camp bolus of the future for the Army side of things, the work that the 711th Human Performance Wing is doing at Wright-Patterson, what the 59th Medical Wing is doing. That's a research side of this, but they're obviously down in San Antonio. What ONR is doing in the research space, what our synthetic training environment folks are working on. I try to maintain situational awareness of all those things. It's a big enterprise in our training spaces. But I would say that we continue to try to do across the enterprise realistic training as much as possible. Our holdup for most medical realism is usually Class 8 supplies. When we go to most of our training spaces, Class 8 supplies are expensive, and oftentimes we don't train with the supplies and equipment that we would use when we go to war. And because we don't use those supplies, we don't break open all the kit, and we don't use that to take care of some of our simulated casualties, some of that realism of the training will suffer. How much that affects the patient outcomes, I think, is still uncertain. I know that for our data collection purposes, though, that makes it really difficult because the machine doesn't see you using it, and the machine doesn't know that it's going to be used. So whenever we're doing our research training lanes, or our research lanes for collecting data, we require that those lanes, those data collection events, include as much as we can, high fidelity med sim, which includes using your Class 8, and hyper realistic med sim, difference there being mannequin patient versus live actor patient. And the live actor side, obviously, you get to talk to the medical provider, you get to scream, you get to yell, you move. You have to have the right tools and right simulation attachments that allow you to do procedures on the live patient, whether that's a cut suit or some of the other, I would say, simulated attachments that are, I think, coming out now, which I like better than the cut suit personally. They're less bulky and they make it a little bit more real in many circumstances. But you can make, again, training very, very realistic in nature. I think as we bring the data collection and the research space together with the training space, the data that we collect from that will evolve into better training, and it'll evolve into novel ways of training. So camera to augmented reality or virtual reality. There's most of us, and I would imagine many listeners, have put on a set of VR headsets and even AR headsets and have tried to do some sort of casualty care with them. If you've gone to any medical conference in the last year, 2 years, there's almost inevitably some AR VR training vendor there that's trying to say, hey, this is the best thing in the world. And they're getting better. They're absolutely getting better. But they don't give you necessarily the smell and all the haptics, the feel. Those are still technologies that are very far behind in terms of compared to the visual training aids that exist. Being able to have to root through your bag to find something and to pull it out, and the physical muscle memory that's necessary for ripping open, certain pieces of kit, or drawing fluids from with a syringe out of a vial. Those muscle memory things are really important to patient care. And if you've ever watched somebody fumble doing that, or drop a needle or drop a vial, and then have to go grab it as it's rolling away, you realize the skill set that is involved with doing those types of repetitive tasks over and over again are important for training. And I don't personally think we do it quite enough. I think that we will always require some sort of high fidelity, maybe even hyper realistic med sim to really train ourselves. And the other part that's important for the data collection space, that we only do it right now, really for the individual providers. Very few team-based training environments that we have in play. And the ones we have are usually isolated to one team, and we're not really thinking about the entire care continuum. And that care continuum becomes really important when you're starting to think about managing large-scale combat operations. How do we model the entire care continuum in such a way that we can optimize both the triage of casualties at the point of injury, and then the resources needed to manage those casualties across the care continuum in real time in such a way that we can optimize the path of an individual patient to go to role 1 versus role 2 versus role 3, all dependent upon the resources that are actually at each of those different locations and the requirements that that individual patient has to optimize their outcome within the context of the battle that's ongoing. That's a big ask, and we don't have the ability right now to rinse, lather, repeat those types of models or that type of data collection in the real world. We can do it on a tabletop, but the problem with the tabletop is if we develop those models and we don't validate them with real world data, I don't know if the humans will trust them. And if the humans don't trust them and the machine says that casualty is not going to make it, you go to that casualty instead. If the human doesn't follow that recommendation, is that going to affect the entire care continuum? Is that going to affect the optimization of the algorithms that are going to make sure that most casualties live? The answer is yes. So we've got to develop a system where we actually trust the output of our tools to help us make the right decisions so we can maximize the outcome for all the casualties in the system if we want to try to achieve the 98% survival rates that we talked about at the very beginning of the podcast.
We've been speaking with Dr. Jeremy Pamplin on WarDocs podcast. Jeremy, thanks again for sharing your experiences, your insights with us, all the fascinating things that TATRC's doing, and thank you for your service. We really appreciate what you do.
Thanks, Doug. I really appreciate, again, you having me on the show again. I really appreciate the work that you're doing to, you mentioned the drop-off between wars and the whole concept of the Walker Dick. You know, I truly believe that the yeoman's work that you're doing, talking to all of us folks across the services, both in and out of uniform at this point in time, is making a difference for us to retain some of the lessons learned, and really drive the best possible patient care that our system can deliver. So thank you for the work that you're doing. Really appreciate you.
All right. Well, thanks again.
Thank you for listening to WarDocs. We sure hope you enjoyed it. WarDocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team WarDocs on WarDocsPodcast.com. Thank you for your support. If you like war stories and medical drama, WarDocs has you covered. Spread the word.